So, as I say, my name is Lindsay Brown, and I work with the Interstitial Lung Disease Service primarily in St Vincent's University Hospital in Dublin, and my role is a Respiratory Advanced Nurse Practitioner, full stop. Now, I'm going to give you a definition of oxygen therapy. So it's defined as an administration of oxygen at concentrations greater than those found in ambient air. What we mean by that is room air. So room air has a 21% concentration of oxygen in it when it's dry and at sea level or ground level. And there seems to be a misnomer out there amongst the general populace that the reason for giving someone oxygen therapy is for breathlessness, and that is not the case. Oxygen is a treatment for a medical term that we call hypoxemia. So that means you've got low blood oxygen levels. So the rationale for giving someone oxygen therapy is to treat or prevent hypoxemia, thereby preventing what we call tissue hypoxia, so low oxygen levels in the tissues of your, or the organs of your body, which ultimately, if that's allowed to proceed, can result in tissue injury or cell death. The other reason is to give oxygen is to try and reduce some of the work of breathing that's necessary for someone to maintain their arterial blood oxygen levels. Now, in every cell in your body, there is a little structure. I like to think of it as a factory for producing energy. Its fancy name is a mitochondria. And mitochondria need oxygen to produce or to convert adenosine diphosphate into adenosine triphosphate. And by so doing, it produces energy for a cell to basically do the work that it was designed to do. So it's a very important structure, and it highlights the importance of oxygen in your body and in the functioning of your body. Now, we talk about an oxygen cascade, and that's about how much oxygen's in the air that you breathe in versus how much oxygen actually reaches the mitochondria in the cell. And that's influenced by a lot of issues, which include gas exchange in alveoli in your lungs. That's the little air sacs in your lungs that oxygen diffuses through from the air into the bloodstream and then gets circulated around your body and your bloodstream to the cells. And it also, therefore, is important that your tissues are well perfused, so they've got a good blood supply. And that you've got the facility to transport oxygen in your blood, which is carried in hemoglobin, so it can be influenced by things like if someone's got anemia, so a low hemoglobin level can impact on that. And obviously, if you've got any underlying lung pathology or an alteration in structure or function, that can lead to tissue hypoxia or low oxygen levels at the tissue level. So I know that's a little bit technical, but hopefully you'll have grasped the essence of it. Now, one of the things that we talk about in the hospital, and you might have heard people talking to you about it, is target oxygen saturations. So essentially we put little probes called an oximeter on your finger when you come to clinic, or an earlobe or your forehead if you have bad circulation in your hands. And that tells us what your peripheral oxygen saturations are. It's not telling us what's happening inside the artery in your blood, because that would be an arterial oxygen saturation. And we can't find that out in a non-invasive way. So target saturations for the majority of people who do not have any underlying health problems, who present to a hospital, perhaps with an acute illness, would be between 94 to 98%. However, there are those individuals who have underlying conditions that result in them under-breathing or hypoventilating. And those people can end up retaining a waste product from cellular metabolism called carbon dioxide, which normally you would breathe out, but sometimes people retain that. And in your bloodstream, you've got little receptors that pick up on oxygen levels, carbon dioxide levels, and also hydrogen ion levels. So they look at the pH of your blood. Raised carbon dioxide levels can make your blood more acidic, and that's a problem because it causes a problem called respiratory acidosis, which can make you very sleepy, very drowsy, and it can be problematic. And the difficulty is that your body's means of compensating for an elevated carbon dioxide level is to monitor low oxygen levels in the bloodstream, and that becomes your stimulus to breathe. So in people who've got low oxygen levels and high carbon dioxide levels in their bloodstream, we have to be very careful about how much oxygen we give them in a hospital scenario. So because of that, we give them low amounts of oxygen just to maintain target oxygen saturations of between 88 to 92%. And that is very crucial because if we give them too much oxygen, we can remove their stimulus to breathe. Okay? Now,
Lindsay,
in interstitial, yeah?
I apologize for interrupting you. Can I ask a favor?
Yeah.
Can you turn your camera around and just check and make sure, number one, that we're on the right slide. And then secondly, could I ask you to turn in the Teams meeting, can I ask you to turn your video off because you're breaking up just a tiny bit.
Okay. Right, done.
Perfect.
Yeah.
And we're on the right slide?
No problem. You are indeed. Yeah, I've added a wee bit further explanation, but we are on the right slide. Okay,
perfect.
So,
thanks, Lindsay.
And then finally, no problem. And then finally, where we're talking about interstitial lung diseases or fibrotic lung diseases, we actually look to achieve target saturations of ideally around 90%, but we're happy if they're above 85%, because 90% is not always achievable with progressive interstitial lung diseases. Now, we're happy enough because we know we're not going to cause tissue hypoxia. So that's the key thing about it. But also what you've got to be cognizant of is that oxygen therapy in interstitial lung diseases doesn't actually afford any survival benefit. The reason for giving it is to encourage exercise and to improve people's functional ability and therefore help to improve their quality of life. All right. But if oxygen becomes burdensome for somebody with interstitial lung disease in that they stop doing any activity because they're having to carry or lug something heavy around that they cannot do, then it may be considered a quality of life issue to not give them oxygen therapy. But that's discussed on a case-by-case basis. Okay. So, and the final point in that slide I don't really want to dwell on, but basically, if somebody has normal oxygen saturations and then they suddenly drop by a factor of about 3%, you have to investigate what's going on there. Why is that happening? So that brings us on to, okay, well, you've got target saturations, but how do we go about doing an oxygen assessment? So essentially, we do the baseline room air oxygen saturation level using the little probe on the finger, and that will tell us your heart rate also at rest. Then we do what we call a 6-minute walk test, which is an internationally recognised standard test where you walk somebody for 6 minutes at their own pace on the level. and you measure their oxygen saturation and their heart rate at generally 30-second intervals. And you also ask them about their breathlessness score, which is a Borg score from 0 to 10. And we monitor the distance that you walk. And we use that for comparative purposes over subsequent visits. Now, the HSE, as you know, has brought in a new oxygen prescription form that everywhere around the nation has got to utilise. And they're stipulating that the institution that prescribed your oxygen has to perform an annual review. So an annual 6-minute walk test or an annual oxygen assessment at the very least to re-evaluate your requirements and to reissue another prescription to the HSE if they're funding your oxygen, or to the oxygen supplier, as the case may be. But there are other critical times when you should do oxygen assessments, and that would be during acute illness and leading up to discharge from the acute illness, so that you might need a higher amount for a short period of time being discharged from hospital, say following an acute exacerbation. But you should be re-evaluated round about 8 weeks following discharge to re-establish if you've returned to your original baseline, or do you have a new baseline, but it might be less oxygen that you required at the point of discharge from the hospital. Similarly, sometimes we are prompted to do a 6-minute walk test by your result of your breathing test that you've had done in the lab that looks at your lung volumes and your DLCO, which is the diffusion capacity in the lung, so the ability for gas exchange to happen at the air sac level. Or it might be prompted by you self-reporting a decline in your exercise capacity, or by increased exertional symptoms. Now, sometimes if someone's resting oxygen saturations are less than 90%, it would prompt us to do a more invasive procedure called an arterial blood gas. So that tells you what your oxygen gas tension is in your arterial blood flow. And we do that primarily to see, are you retaining carbon dioxide? Because obviously that's going to impact in the amount of oxygen we can give you. And the other thing that we do is something called overnight oximetry, because sometimes people can be saturating all right awake at rest, desaturating on exertion significantly. And when they go to sleep at night, you use different muscles to help you breathe. You don't use your rib cage muscles, your intercostal muscles, you rely on your diaphragm. So quite often that can result in a drop in oxygen levels when somebody goes to sleep. And it depends on how much that drops and the frequency by which it drops as to whether we would need to give you oxygen therapy while you're sleeping at night. Now, that test by and large can be done by oxygen suppliers, and it's called overnight oximetry, and they can do it in the comfort of your own home, which is much more natural anyway. So that brings us on to an oxygen prescription. So people don't think about oxygen as a drug, but it's classed as a medication, and therefore it requires a clinician's prescription. Now, in a hospital setting, we've got systems in play whereby oxygen is prescribed on our medication record chart, or we now have a new oxygen prescription chart specifically for that purpose. And in that, it measures something called your FiO2, which is your fraction of inspired oxygen, or it measures litres per minute. So fraction of inspired oxygen is measured in percent, and the flow volume is litres per minute of oxygen. It also measures the delivery method, the duration for which you have to be on oxygen therapy, what your target saturations are, and when it's going to be reviewed, be it in a date or a time. Sometimes for people with, say, extremely low oxygen levels, we bring in other more extensive therapies like high flow continuous positive airway pressure, or an AirVo, which is high flow heated humidified oxygen, or non-invasive ventilation, and oxygen can be entrained into those systems. But it's all recorded in a healthcare record for posterity so that we can look back and refer to that. In terms of home-based oxygen, that can be prescribed by a medical staff, or it can be prescribed by an advanced nurse practitioner who has got prescribing rights. And that's done on a standardised form now called a HOOF. And it's either sent to the community health office to be approved if you have a medical card, or it's sent directly to the oxygen supplier that is assigned to your geographical area in the country. We don't really have any control over that now. So the next slide is an indication of the oxygen suppliers and the areas that they cover in the CHO. So there's two companies, and I'm not going to dwell on the areas that they covered because you'll be able to see that in the slide, but there's basically two companies covering the geographical area of Ireland. One is called Air Liquide, who were already in existence in Ireland, but the difference to them now is they never used to offer the provision of liquid oxygen systems, and they do that now. And then a new company has emerged onto the market, and they're called Vivisol. Now, they're well set up in the UK, so they've got a wealth of experience to bring to bear. And they also will supply all manner of oxygen therapy devices to meet virtually anybody's needs. Okay, so if we go to the next slide. So this slide is called oxygen interfaces. So basically that's the delivery device that we use. Now, by and large, the majority of people in the community setting are given what you call nasal cannula, which is highlighted as B on the diagram in the top left-hand corner. Next to that, highlighted as A, is also a form of nasal cannula, but these are used with the AirVo, so high flow heated humidified oxygen, generally used in hospital settings. It's a rarity that it's used in the community. On the top right-hand side, some of you might be familiar with this. This can be used for people who perhaps have got painful nostrils and crusting from wearing nasal cannula with high flow oxygen. And it's called an oxymask. Now, I'll go through each of these devices in turn, but that's called an oxymask. In the bottom left corner is a mask system again, which is called a Venturi mask, and it comes in a variety of percents from 24% right up to 60% oxygen. And I'll explain how that works. And then the final picture there, which looks like a mask with a plastic bag attached to it, is called a non-rebreather bag. So if we take each of these in turn. So the nasal cannula basically is designed primarily to deliver low and medium dose oxygen concentrations. It is influenced by a patient's breathing pattern and rate of depth of breath, and that can affect the amount of oxygen being delivered to an individual. So we talk about tidal volumes, that's the amount you breathe in and out in one breath, and minute ventilation, that's the amount you breathe in a minute. So nasal cannula are very much influenced by that. Now, in general, nasal cannula will deliver between 1 to 4 litres per minute of oxygen through them, but they can go up to 6 litres. This would be the standard nasal cannula, and that's equivalent, depending on your rate and depth of respiration, of between 24 to 40% if in comparison to a Venturi mask. You do need to use pulse oximetry and oxygen titration to reach your target SATs using nasal cannula. And there are also high flow nasal cannula available, which basically have got a wider bore. They're softer and they can actually be used to deliver up to 15 litres per minute of oxygen through them. Now, the advantages of using nasal cannula are obviously, they're not claustrophobic. A lot of patients prefer them. Overall, they tend to be comfortable. You can eat, you can drink, you can verbalise with them. There isn't a lot of respiratory resistance involved in them. You don't get a build-up of any carbon dioxide in a mask that you could be rebreathing. They're relatively cheap, so that's always a bonus. However, they can be easily dislodged. High flows through it can cause nosebleeds. It can cause dryness of the nose, kind of rawness, and it can cause crusting of mucus. It can be impeded if you've got a lot of thick secretions and they block the nasal cannula outlet. It can be interfered with if somebody's got a deviated septum from a previous broken nose, perhaps, or if you've got nasal polyps, so growths up your nose, that can impede with that. Now, moving on to the high flow nasal cannula, these are the ones that are used with the airflow. Tend to be used in a hospital, but they can give up to 100% oxygen through them and 60 litres per minute of flow behind that, which is pushing the oxygen deeper into the lungs and helping to recruit alveoli or air sacs that are perhaps a little bit shut down in themselves. Also, you can adjust the temperature of the heated humidification from between 31 to 37 degrees. 37 degrees tends to be used with people who are intubated or have a tracheostomy, so doesn't tend to be done through the nasal prongs. And it's given through wild-bore nasal cannula, so it tends to be quite comfortable. The advantages of it is it gives good humidification, can help with chest clearance, recruits the alveoli, and that's what that means by functional residual capacities improved. And it helps with clearing mucus from the lungs, and it gives humidification and high flow. And it also reduces the amount of work that somebody's got to make to breathe. Moving on, the Venturi mask is a very precise device. It gives exactly the percentage of oxygen that it says is going to give somebody. So, but the oxygen flow has to exceed the person's expiratory flow so that there won't be breathing in room air along with it and diluting the percentage. And that's the way that's designed. For those of you who like physics, you can look up something called the Bernoulli effect, but that's not my bag. So the advantages and disadvantages of it is it doesn't dry your mucous membranes because you're using a mask setup, but it's confining because you've got to be attached to wall-based oxygen and you can't really use it through a pulsed flow device. It's got to be used through a continual flow device, and it will interfere with eating, talking, can be a bit claustrophobic. But it's useful in a hospital setting where we need precision about the percentage of oxygen that people need. And that might be in the scenario where you've got somebody who's inclined towards retaining carbon dioxide, which could be somebody with COPD. And then finally, you've got the non-rebreather mask. So that's a low flow device, but it can give high flows of oxygen. It can give 100 up to kind of 100% of oxygen, and you can give up to between 10 to 15 litres of oxygen through that. It has a one-way valve on it between the mask and the reservoir bag, which prevents the patient re-inspiring expired air or carbon dioxide. So the advantages or disadvantages of it, you can't give less than 10 litres of oxygen through this because it's important that the bag stays inflated. It can't collapse when the patient breathes in. And again, it is influenced, the percent of oxygen that somebody gets is influenced by a person's breathing pattern. And the one drawback with this is if someone's nauseated and vomits, there's the risk that they could aspirate or breathe in some of the vomitous. So those patients need to be very closely monitored. And then the oxy mask that we mentioned. Very open mask. It can be used with from 1 litre of oxygen continual flow to 15 litres of oxygen continual flow. You can't use pulsed flow oxygen with this. Again, it will be influenced by someone's breathing pattern, so the percentage of oxygen they're getting will range from 24 to 90% depending on the flow rate and their breathing pattern. But it's a nice wee mask. It's lightweight. You don't tend to get pressure points on it. It's not claustrophobic because it looks like it's got big spaces within it. Patients can still communicate. You can use drinks through a straw. You can take oral medications. There isn't a risk of aspiration because, again, there's large openings. It can actually be worn while people are getting procedures done, like a bronchoscopy or a CT scan or an MRI. You don't get rebreathing of carbon dioxide in this mask. Very simple flow adjustment on it, and people tend to adhere to their oxygen therapy when they use it. It's cost effective and there's no latex in it, so there's no risk of allergies. Okay, so we can move on, and what we're going to do in the next slide is just look at a little bit of some of the equipment that's available in the community to you. So we'll start in the bottom left corner, and there should be a blue machine which is on casters, and that's called a standard oxygen concentrator. It is a static machine. However, it's got casters so you could move it from room to room if you were wanting to, say, put it to the nearest socket to your back garden and go out for a little walk in your back garden. It can only go up to 5 litres per minute of oxygen, no higher. You can piggyback 2 of these machines together to achieve 10 litres per minute of oxygen. The other machine on the bottom left-hand corner next to that, which is a grey machine, is also an oxygen concentrator, a static one, but it's a high-flow oxygen concentrator. And depending on the model, it can give you continual flow oxygen of between 9 to 10 litres per minute. Again, you can piggyback these machines to achieve up to 20 litres. You can piggyback 3 of them to get more than that. And sometimes that's done for patients who might be awaiting lung transplantation, who need high flow oxygen. So it's a noisier machine. That's the only drawback with it. And the other thing you've got to be mindful about these machines is that usually the companies give about 30 foot of extension tubing with them, and then your 6 foot nasal prongs are attached onto that, or your connection tubing for your mask. You have to be mindful of, if you want to extend the length of that tubing, that will impact on the flow of oxygen that actually you receive through the nasal prongs. Okay, so that's an important point. And the other thing is we don't use cold water humidification with these machines. Some people ask us, can I not get a humidifier? But the length of tubing required for you to get around your home with one of these machines makes it really negligible giving you a humidifier, because it will never reach the end of the cannula. Plus, cold water humidification is an infection risk if you don't clean the reservoir for that adequately, and therefore you can get gram-negative infections or pneumonias in the chest, and we want to try to avoid that. So further, if we look in the top right, no, sorry, the top left corner, there's a little machine with wheels on it. It's called Eclipse 5, or it's a sequel Eclipse. This is what you call a transportable portable oxygen concentrator. And it can give up to a pulsed flow of oxygen setting 5. Now, I'm going to say a wee bit about pulsed flow oxygen. It is not the same as continual flow oxygen, all right? You have to activate a pulsed flow device by breathing in through your nose. If you don't breathe in through your nose, you won't activate it and you won't get your oxygen delivered, okay? And on a pulsed flow, you cannot use a mask. Okay, it doesn't work. However, the sequel Eclipse can also do continual flow up to 3 litres per minute of oxygen. That's the maximum you can give through it. So for some people, it's a useful device. It is the size of a small suitcase, so you need to be able to wheel it about on a trolley, but you can take it on an airline. Okay, it's covered for that if you've got medical clearance and you've got clearance from the airline to bring it aboard. Now, moving along the top row, you'll see 3 devices that all look fairly similar, and they are relatively similar. These are what you call portable oxygen concentrators, or POCs, and they only give pulsed setting of oxygen. And only one of them can go up to a maximum of setting 6, and that's the Inogen Rove 6. The other 2, which is called Care Freestyle, and the Inogen G3 or G5, they can only go up to setting 5 pulsed flow. Okay, so there are limitations with these machines as to who they are, well, useful for in terms of benefiting patients. Then in the top right-hand corner, you've got your bog standard cylinder-based oxygen, which comes in 2 different sizes. You get a B1, which is the lightest cylinder, or a B2 cylinder, which is a heavier cylinder. The B2 has got 400 litres per minute of oxygen in it. The B1 has got 200 litres per minute of oxygen in it. So it won't last as long on a continual flow. But you can get a little conserver devices with these cylinders if it's appropriate for you, which means that the cylinder will last longer because it makes it a pulsed flow oxygen delivery system. Now, if we go to the bottom or the row in the middle, you'll see these kind of stainless steel cylindrical devices, and that is liquid oxygen reservoir tanks, or mother tanks. And they come with the devices, the portable devices, to the just to the right of that. Now, in terms of interstitial lung disease patients, I tend to use the high flow stroller units where I'm using liquid oxygen, because that's the only one that supplies continual flow oxygen. But there are pulsed flow devices available also for other patient groups where it's appropriate. Usually people would get maybe between 2 reservoir units, but you can get up to 4 of the reservoir tanks a month. And if you get 4 reservoir tanks a month, you get 2 of the stroller units. And these are refillable devices. They can only deliver the reservoir tanks to people whose houses are relatively on the level, or they've got no more than 2 steps up to their door. If it becomes a health and safety risk to the employee of the oxygen supplier to try and install that into, say, an apartment block where there isn't a lift system to get it up. So that's some of the devices that are used. And then coming on to how oxygen's funded. So if you've got a general medical card, then the HSE will fund the package. But if you don't, and you're on the drug payment scheme, then you are really a private patient of the oxygen supply company. You need to pay the invoice to them. Now, my understanding is the oxygen supply companies are now doing this by setting up direct debits, which they will take from people monthly. But you can reclaim the monies that you've paid from the HSE on the DPS1 form if you're above the monthly threshold, which to my understanding is about €85 now, but I'll stand corrected on that. But the key thing is you must pay for the oxygen and send those receipts to the HSE, but keep copies of the receipts, because with all these administrative areas, there are time delays, and you want to make sure that you're keeping tabs on getting your reimbursement for each month. Okay, so this is a rough estimate of the costs. I don't know exactly what the costs are, but if someone had liquid oxygen and say a high flow oxygen concentrator and they got 2 little backup cylinders, that's working out at roughly €300 a month. If you get 12 cylinders a month, regardless of the size, it's around about €100 a month. A portable oxygen concentrator like an Inogen's around about 155 a month, and a transportable portable oxygen concentrator like the Sequel's round about 170 a month, to put that in context. So if it meets with everyone's agreement, and Maureen and Gemma, I'll stop at that point and take any questions that people have got about oxygen.
Thanks for that, Lindsay. So we've got a good amount of chat coming in. One question is, and just to say in terms of the time, we've got just a little bit more than 15 minutes left in the session.
Okay.
So just a couple of questions. Is low oxygen a problem for your heart is one question. I'll give you the other two, and then you can answer if that's okay.
Yeah.
The 85% figure that you used, is that documented anywhere in the guidelines? And would you use the 1 minute sit to stand if limited in clinical space and time? And then there's just a point that's made about the mask was used in the hospital for several days, and it was a good relief of the discomfort. There's a comment there.
Okay. So the first question was, is low oxygen levels bad for your heart? So the problem with low oxygen levels cumulatively is that your body tries to compensate for it. So if you need oxygen and you're not on oxygen, one thing your body does is it produces a hormone, and the hormone makes you make more red blood cells. If you make more red blood cells, your blood becomes thicker. It's a condition, we call it polycythemia. If you get polycythemia, it means that your heart is going to have to pump a lot harder to circulate syrupy blood, basically. And it's not an efficient pump, and the heart muscle can enlarge, and you can get back pressure from the right side of the heart into the lungs, and you can end up with a condition called pulmonary arterial hypertension. So low oxygen levels, yes, are a problem if they persist and they're not rectified. Okay. The question about the sit to stand, I don't do that, but I have heard of that being used in the COPD outreach team when they're doing oxygen assessments in people in their own home, where they haven't got a dedicated area where they can do a 6-minute walk test. So yeah, there's no reason why not. And sorry, what was the other question? Just remind me.
So there's just a couple things here. One is the 85%, whether that's documented in the guidelines.
Oh,
and then there was
yeah. So
go ahead.
It's not documented in the Irish oxygen guidelines, but you will find reference to it in the ERS interstitial lung disease guidelines.
Okay, thanks for that. And then the last one is each person prescribed continuous or pulse on a case-by-case basis, or can one use either?
No, That's the thing. Oxygen's a prescribable gas, so therefore you have to undertake an individual oxygen assessment. You can't go one size will fit all. So it's got to be taken from that individual and observing that individual walk, because if someone becomes pressured when they're walking, they can't talk and they are breathing faster and more shallow, they're more inclined to be a mouth breather. If they become a mouth breather, they will not activate a nasal pulsed device. So it's an inappropriate device for that individual.
Great, thanks, Lindsay.
Okay. Any more questions?
So there's just a few additional comments that have come in. We don't have all the devices available to us, but that might be a deficiency of VOC and not of air liquide.
Will I just say something about that? So BOC are going to be coming out of the domiciliary oxygen market altogether. So any of the patients who are with the BOC should contact whichever hospital they attend to get the staff there to transition them to the supplier in their local area now. Okay?
Okay, great. Thanks for that. Lindsay, we've just about 15 minutes left, and there is, as one of our members has reminded us, cough management still to be discussed.
Yeah. Okay, so I'll crack on. I've only got 3 slides in cough management, so we'll get through that. And then if anybody has any other questions, you could forward them on to me in my email and I will reply to them. Yeah. So in terms of cough management, the first thing that we do primarily is conservative management. So that's using simple remedies. So making sure you're well hydrated is a key thing, because a dry today. Sometimes some people prefer cold drinks or sucking in ice cubes. Other people, it's the entire opposite. They prefer warm drinks. You can suck lozenges. You can use menthol sweets. I've heard people saying that they like Fisherman Friends, that helps them. Honey and lemon can help. Ice cream can help. Or honey can help as well. Thick honey like Manuka honey. And also dark chocolate, because it's got a chemical in it. I think it's called bromelain, which has got some neuropathic benefits. So it coats the nerve endings in the back of your throat. Now it's short-lived, the benefit you get, but then you get the nice taste of chocolate too. So from an educational benefit, sometimes what happens is that people have a cough and they ends up being almost an anticipatory cough, and it becomes habitual, so that you're coughing just regardless. And that does have no physical benefit to that. So in some instances, you can refer people on to a speech and language therapist that look at how you speak and the movement of your vocal cords, and they can help with something that's called dysfunctional breathing in some respects, and that they can help kind of desensitize your cough reflex somewhat. So the key thing is to avoid irritant environments and things that you know trigger you to cough. And the other thing to be mindful of is that you do have voluntary control over cough, so you can consciously control it. Sometimes people use psychoeducational techniques, so like cognitive behavioural therapy, and I know some of the nurses have been trained in that through ILFA. Or you can keep a cough diary to indicate when you're coughing, how long it lasts, the nature of the cough, the describer, and that can be helpful to bring along to a clinic. If it's a productive cough, then you can use mucolytics. So they break up mucus strands, and you may have heard of Exputex, which you can buy over the counter. There's other ones called Mucodyne, and it's helpful if you can be taught something called the active cycle of breathing technique or forced expiratory technique to aid with energy efficient chest clearance. Then, of course, you can use cough suppression. So that's instead of coughing, you give a huff, which is much more gentle, less irritating to the throat. Swallowing, again, drinking ice cubes. And then you're talking about bringing in medications such as codeine linctus, which is a cough suppressant but has got addictive properties because it's an opiate. Similarly, you can use morphine patches, or you can use Oromorph on an as required basis. You've got to make sure that you've addressed other comorbidities that can contribute to cough. So that might be gastroesophageal reflux disorder. So that could be prescribing someone either a proton pump inhibitor or an H2 antagonist, or even domperidone, which is a medication that speeds up gastric motility, so your tummy empties quicker. So that is important. And incidentally, the gastroesophageal reflux medication has been shown to decrease radiologic fibrosis and is an independent predictor of longer survival time, and the reference is there for that article. The other thing is controlling postnasal drip. So that could be by doing isotonic Neomed sinus rinsing. Sometimes people get prescribed intranasal corticosteroids. You might use antihistamines. Depending if someone's got a background of asthma too, they might also use leukotriene receptor antagonists that can help. Further than that, we might do an ear, nose and throat referral. I mentioned speech therapy already, where they can teach vocal hygiene. And they help with reducing the rate and degree of cough receptor stimulation, reduce laryngeal irritation and peripheral sensitivity. And then the other things that can help with cough is not mouth breathing, but nose breathing, where you're filtering the air that you breathe in, you're warming it, and you're hydrating it. You could use steam inhalations if that helps you, or you can do diaphragmatic breathing where you're relying on your diaphragm, more relaxed breathing, and that's less inclined to cause coughing associated with deeper breathing. The speech and language therapists talk about vocal misuse, where people that are inclined to cough don't want to speak loudly, so they get into a pattern of whispering, which therefore will impact on the tension in their vocal cords. You should reduce caffeine intake. It's associated with spasm in the airway. Alcohol intake, spicy foods, dairy foods can be mucus producing. Spicy foods and dairy foods can increase gastroesophageal reflux. Cough sweets, things that would induce cough, stop taking them, but try more conservative things like honey and lemon, and certainly stop smoking, because that will stimulate cough. The other things about cough management is rule out whether someone's got obstructive sleep apnea, where they've got laxity in the palate, in their mouth, and it can collapse down when they lie down, and it ends up with excessive snoring, and that can stimulate cough. Sometimes if someone's on oxygen therapy, they might desaturate when they're coughing. So by increasing your amount of oxygen that you're taking to maintain your target sats while you're coughing, that can help. And it may be, if it's a really intransigent, troublesome, persistent cough, it may be possible to consider something like heated humidified airvo in the home. Never really seen that done a lot, unless you had an awful lot of secretions that were thick. There is a suggestion that gabapentin and pregabalin, which are both neuropathic agents that are taken orally, can help cough. But in general, I haven't found that any patients that were trialled on that got any benefit. There is evidence to support the use of a drug called thalidomide, which you may recall many years back being associated with being used in pregnancy for nausea and vomiting involved with that. However, it's a drug that's fraught with side effects. It can cause deep vein thrombosis, it can cause pulmonary embolism, it can cause peripheral neuropathy, it's teratogenic to a fetus, and it's also exceptionally difficult to prescribe. The doctors need a special license to do that. So I've never seen it used. And then it is possible where you've got real difficulties with cough, where you can rely on, say, quality of life questionnaires, of which there are a few, where you can get a baseline quality of life score, try an intervention and reevaluate as to whether that's making some impact. And then I suppose you could do palliative care referral for symptom relief from their perspective. Sometimes they might use anxiolytics, so that's anti-anxiety drugs. Sometimes they might use hyoscine patches behind your ear, where that'll dry up secretions if you've got a lot. And sometimes the mainstay of what they would use would be opiate related. So that helps reduce perception of breathlessness and cough reflex.